Alrighty, good afternoon, good evening, good morning, wherever you're tuning in from. We're so happy to have you on to another NSWOCC and Walk Institute Continuing Education webinar. Today's presentation is brought to you by Solventum, and we thank them so much for their continued partnership. We're going to be talking about optimizing wound care, helping clinicians choose the best negative pressure wound therapy for wound healing. And we're joined today by a guest speaker, Dr. Karen Bauer, who we'll introduce in just a second. But before we get to that point, let's do a couple little housekeeping items. First things first, I'll get everybody in the audience here to click on the chat button in your Zoom toolbar. See, we've already got people posting in there. You guys all know my game. Let us know where you're tuning in from. I'm Troy. I'm our Director of Operations for Nurses Specialized in Wound, Ostomy, and Continence Canada. I'm tuning in from Ottawa here, and it's great to see you on. We're going to be doing a Q&A portion at the end of today's webinar. So if you do have any questions, don't use the chat button, but use the Q&A one in your Zoom toolbar. That'll make it easy for us to organize everything and get to as many as we can at the end of the webinar. We're also recording today's session, so if you have to head out early, or if your colleagues want to go and watch this back again later, it will be available on our nswoc.ca website. You will also be receiving a certificate of attendance, so just give us a day or two to get those into your inbox, and we'll be happy to do that. There'll also be a survey after this webinar too. It should pop up in your browser. Make sure to take a second to fill that out. We're also going to include it in your post webinar email that's going to include your certificate of attendance too. So we ask that you just take a minute or two to complete those as well. So without further ado, I'm happy to introduce Dr. Bauer, who is a wound board certified nurse practitioner. She earned a Bachelor of Arts in Sociology from the University of Toledo, a Master of Science from the Ohio State University, and a Doctorate of Nursing Practice from the University of Toledo as well. She currently practices at the University of Toledo Medical Center and affiliated outreach sites. Dr. Bauer also serves as the president of the Society for Vascular Nursing and is a longtime board member and fellow of the Association for the Advancement of Wound Care, where she also co-chairs the Education Steering Committee. In addition, she is a member of the American Heart Association's Peripheral Artery Disease National Action Plan Steering Committee, and is on the editorial boards of several scientific journals. Is an active lecturer at regional, national, and international events, and is a published author. So without further ado, I'm happy to pass over the mic and the slides to you, Dr. Bauer. Thanks for being with us today.
Awesome. Thank you so much, Troy. I really appreciate it. I'm really excited to be here. This is honestly one of my favorite things to talk about, and I'm hailing to you, depending on where you are, just about an hour south of Canada. So I'm currently in Toledo, Ohio. Like Troy said, I actually am mid-career change, so I'll be headed down to Emory here shortly in Atlanta. But again, really excited to be here and to talk about this really important topic and go through some of the new developments and things that we have on the horizon. So disclosure, I am a speaker for Solventum. With that, I always qualify that I speak for companies that I use their products already, right? I'm not going to use a product because I am a speaker for said company. And we'll talk about that a little bit tonight, just the commitment to research and development and innovation and the evidence base and making sure that we're really choosing the right therapies for our patients at the right time. And I appreciate Solventum's commitment to that. So you can see the most important information that we'll get tonight, right? We can scan that quickly, and then we will get right to it. So first I want to kind of address something that likely we all know, but I think cannot be emphasized enough, that complex wounds, hard to heal wounds, kind of going away from that word chronic and trending toward the hard to heal. Wounds never occur in a vacuum, right? So we can have a venous leg ulcer that's going to have a diabetic component, that's going to have a pressure component, that's going to have an arterial component. So we really have to address all of the patient level factors, but we also have to address all of the systematic factors, the local factors, really complex things. So essentially a hard to heal wound is a wound on a patient, right? On a complex patient. Lots of barriers that we have to wound healing that, again, kind of preaching to the choir, but I want to make sure that we emphasize that as we're talking about what devices and what dressings we need to be using when, there's so many things that we need to look at. We have to make sure that the patient and or caregivers have access to the right care. First and foremost, we have to establish the right diagnosis, right? We have to make sure that we're not only treating the right thing or that primary etiology, but that we're also looking at all of the other things that are weighing into it. We need to make sure we're looking at nutrition, glycemic control, perfusion and circulation, offloading, infection, all of the things, because no dressing or device that we have is going to be optimal if we don't take good care holistically of our patient. We have a lot of local barriers that are going to contribute. Again, if we're not fully addressing the primary, secondary, tertiary, and other etiologies, if we're not controlling those blood sugars, then the local environment of the wound itself is going to be either pro-inflammatory or unable to progress naturally through the wound healing stages. If we have necrosis in the wound bed or non-viable tissue, if the biofilm or bacteria is burdensome to the local wound environment, nothing that we really are going to be able to do if we don't specifically manage that is going to be optimal. We have to understand that wound healing cascade, the proteases or the pro-inflammatory cytokines, the local edema, right? All of the congestion and the inflammation that's going on in the local wound environment. Another thing that we're starting to learn more and more about is the pH of the local wound environment and making sure that we're maintaining appropriate pH. And then lastly, it's really important to make sure that we're addressing any local trauma. And that comes with, making sure that we're repositioning appropriately, that we're offloading appropriately, that we have dressings that are selected that are not going to increase friction or shear or create a maceration situation. So we have to look at a lot of things to really break through that barrier, break through that wall as we're looking to choose the right dressing. We're all pretty familiar with the difference of what's going on locally and in general with a healing wound versus a chronic or a hard to heal wound. We know that in a wound that's progressing normally throughout that wound healing cascade or the wound healing trajectory, we're going to see less inflammation. Those cells are going to be able to reproduce and turn over. We're going to have low proteases, and we're going to be able to see those cells continue to reproduce. When we have the harder to heal wounds, because of all of the factors that we just talked about, we're going to see higher inflammatory cytokines. The cells are not going to be able to reproduce as quickly or as efficiently as they should. We're going to see higher proteases, and therefore the cells are going to essentially go to sleep. They're not going to want to do too much. So it's really important that, again, as we look at dressing selection, we look at all of the chemical things that are going on, and we look all the way from that most minute detail up to taking care of the whole patient and looking at things holistically. I think another thing to mention there that, kind of inherently a lot of us are really, really keen to is making sure we're looking at the socioeconomic factors and the caregiver factors with a lot of our patients. Do they have access to food? If they have access to food, are they able to eat it? Do they have caregivers in the home? So, in addition to all of these local things that we need to look at, we also need to make sure that we're looking at the patient as a whole. So with that, we're going to focus on negative pressure wound therapy this evening. I want to emphasize again that, in wound care specifically, we really do need our industry partners. It's really important for research purposes, as well as, like I said, the innovation. So if you look at how negative pressure has grown and changed over the last 30 years, we've really had 30 years of breakthroughs, right? But each time that we develop something, it is based on the science. It's based on what we know is going on in the wound. And as we learn more, we do better, right? Know better, do better. So we're using that knowledge and that research to be able to then develop tools within the negative pressure profile that can address the things that we're learning about. Negative pressure will always address both the macro strain and the micro strain. So when we look at that, no matter what device we're looking at, the macro situation, we're going to be pulling those wound edges in and up. We're going to draw those wound edges together. We're looking to remove the infectious material and the exudate. We're reducing the edema by virtue of all of that. And we're promoting perfusion simply by getting that cell turnover and creating a lower inflammatory process where we have angiogenesis. On the other side of it, we're also going to create the cell deformation, which is then going to encourage the cells on a micro level to want to regrow and to grow. We're stretching those cells under the negative pressure, which then stimulates them to want to reproduce and grow. With that, I talked a lot here to start kind of on all of those complex factors from the local wound environment all the way up to where the patient lives and what access they have. One of the really great things about negative pressure wound therapy is that there's a solution for almost every situation. We just have to understand kind of where that fits in and when to change and what we're looking at, and have that critical eye when it comes to our assessing our patient and looking at truly what's going on. But we have the devices, the Abthera for the big open abdominal wounds. We have our standard negative pressure. For patients that are ambulatory, there's the portable. We're not going to go through all of those laboriously tonight, but we are going to go through some of them, especially the more innovative and recent. With that, I talk about critical thinking and being able to think through kind of when to use what. I do want to emphasize that Solventum does have great tools as far as algorithms and patient educations and things that are available to us, that if we are questioning, one, picking up the phone and calling a friend, but two, being able to use some of the algorithms and the patient education material that is available to us already. So with that, I'm going to go through one of the newer innovations. A lot of you are probably familiar with this. I will say that I was a later bloomer with regard to this particular dressing. I think that, negative pressure, one of the things I love about it is so tried and true. I was trained 20 years ago on, we were cutting the foam and the 1-2 blue and the acrylic drape. It was a really hard transition for me to make this transition, but I can honestly say that now that I've used the hybrid drape, it's something that I will never go back on. So with the acrylic drape, we're used to having to do the 1-2 blue, right? We're used to having to remove multiple layers. To protect the wound edges, we're often having to use hydrocolloid, or we're using drape to actually window pane so that we don't end up with the foam against the skin. To improve the adhesion of the acrylic drape, we're oftentimes using skin prep, and I can remember being in there and dabbing a wound, and then it drains a little bit, and then I'm dabbing it, and then it drains a little bit, and then I'm putting gauze under there to try to absorb so that I can get the drape down on dry skin. We no longer have to do that. The extensive cutting that's involved with the old drape and making sure that you get things just to size. And then, like I said, the use in dry conditions. The hybrid drape is going to solve a lot of those challenges. It is a single liner, so essentially you can peel in place. You need to window pane less because of the hybrid drape, because of that silicone layer. It's safe to be against the skin. We are not using skin prep with the ancillary or with the hybrid drape, which we'll talk about. You need to do less cutting, and you can use it in dry or wet skin conditions. So this advancement alone in the drape that we're using is a significant advancement in our ability to optimize the use of negative pressure with our patients. I am going to go through this just a little bit because as we go on tonight, we're going to talk about the novel, one of the newer dressings of negative pressure. And I think that this really plays into what we're going to talk about. But essentially, this silicone acrylic drape provides that ideal balance where inside the circles where the acrylic is, we're still getting that seal, right? We're getting the adhesion that we need. But the silicone, which is outside of the circles, one allows for some repositioning as we're placing the dressing. So I don't know about you all, but when I'm using the acrylic dressing and it gets stuck on your gloves or it gets stuck on the patient's skin, and you're having to pull it off and then it ends up in a ball, and you have to throw it away and then you're waiting to get more. We've really negated the need to do any of that because the silicone layer is going to allow us to reposition it some, and it's a bit more gentle on the skin. So you can see the application here. You do want to leave that white handle as you cut. You want to cut that way so that you still have the handle. You want a 5-centimeter border around the wound edge, but it's essentially a peel off in place. We no longer have to do the 1-2 blue. If it does stick to your gloves or to the patient, and I don't know if you're all like me, but I can remember sitting in rooms with the acrylic drape and the self-cut foam, and I'm wanting to get everything perfect. I want it to look nice, right? I don't want it to be like I'm wallpapering something and I'm just constantly putting over. That hybrid drape really allows the ability to remove and replace in the exact way that you want to. You don't want to stretch that drape because it can lead to tension when it draws down or you apply the negative pressure. You can reposition it, like I said, with those handlebars, and it takes about 20 minutes to cure. So you have about 20 minutes to reposition before that adhesion is really going to take full effect. With that, this is a paradigm shift, right? Because I know, oftentimes, especially with a negative pressure and, like I talked about with the acrylic drape, where I'm trying to get things really dry so that I can optimize how that drape is adhering to the skin. We do not use this skin prep with the hybrid drape. One, because we found that we really don't need it, but two, it does change and adhere to the acrylic portion of that, or the silicone portion of the dressing. Okay, so we kind of gone through the drape. The next thing that I want to go through just kind of very quickly is the negative pressure with instill and dwell. This is another solution from Solventum that was life-changing for me. My practice is both acute care, post-acute care, and ambulatory. So I have the luxury of being able to see my patients in the hospital, in the clinic, and then in the post-acute care setting as well. The negative pressure instill and dwell is currently in the States only available in the acute care setting. But like I said, I'm with a vascular surgery practice, so this has really allowed me to provide the best care and optimize the care of my patients in the acute care setting. And we'll go through some cases later that'll kind of highlight that. But essentially what we're doing is instilling fluid into the wound, into the foam, letting it sit, and then pulling it out. We still get all of the benefits of negative pressure. So you still have that negative pressure phase where you're getting the macro strain, you're still getting the angiogenesis, we're still removing, we still have the micro strain. But now to address the bioburden issue, the biofilm issue, as well as just, especially in the acute care setting and for some of the things that we deal with, really cleaning up that wound. It doesn't add a lot to the application, which we'll go through. There are different dressings that are available for this. So depending on the depth of the ulcer that you're working with, you have that thin layer that has the 5 millimeter spacing there. That's going to create columns. That's going to allow that fluid to really instill and the negative pressure to be distributed. You have a thin cover layer and then a thick cover layer that will go over that. So again, we can kind of tailor the dressing to the patient and the wound that we're working with. And then you can see with that reticulated open foam dressing where that fluid and the granulation tissue is really coming up there through those little holes. The negative pressure instill and dwell does have the smart feature. Not everybody that I work with uses that. Some people like to do it manually. But essentially what you can do with the device is, you put the dressing on and then you do the automatic function and it will tell you how much fluid needs to be instilled. You can see there, you essentially hang the IV bag. There is another tubing that goes alongside the traditional vac tubing that allows for that installation of the fluid. But you can set the machine to do that for you so that you don't have to sit there and be calculating how much fluid and worry about overfilling the dressing and having it not adhere as well as it really should. There are lots of studies on the negative pressure wound therapy instill and dwell. A 2021 meta-analysis had about 720 patients. The key for me in deciding who I'm going to use this dressing on and who I'm not in the acute care setting is essentially those patients that have high comorbid factors. They're at risk for need for serial debridement. So a lot of our diabetic feet, sacral pressure ulcers that are fulminantly necrotic and we debride them. Maybe patient isn't fully optimized yet or isn't fully offloaded yet. We suspect that there's going to be some renecrosis because this dressing has shown the capacity to decrease the need for serial operative debridements when we are using it. This is another little bit of a paradigm shift for us because I know when I was trained on negative pressure, you couldn't really have necrotic tissue, right? You didn't want that sloughy tissue at the base of your ulcer for the negative pressure use. But with a negative pressure instill and dwell, we can, right? So we don't need it to be fully 100% granular to use it, and we can decrease those OR debridements. The negative pressure wound therapy group also showed reduced bacterial count, which makes sense. We know that the traditional negative pressure is going to pull that exudate and pull the bacteria, but now we've added the fluid that seeps in and can kind of wash that out and pull it out. And we'll talk about which solution to use here in a minute. The dressing also showed the capacity to shorten the time that we need to use negative pressure, as well as wound closure. So patients who were treated with the negative pressure instill and dwell initially actually went on to close more quickly. There are also studies that show that we have increased granulation tissue. When you compare the negative pressure, the traditional negative pressure to the negative pressure instill and dwell, we're actually seeing that the granulation tissue that is formed is a much more healthy and more quickly formed granulation tissue. These studies were done with saline, so we're looking at this with normal saline. When we look at the negative pressure in still and dwell and what solution to use, most of the studies show, depending again on your environment and what there is access to, that saline is just fine. We are going to get the benefit of the negative pressure in still and dwell with saline. Having said that, there are studies looking at hypochlorous acid, which can also help with regard to the bacteria. We do want to, as much as possible, avoid those agents that are going to be cytotoxic. So when I'm deciding what solution to use for the wounds that I'm going to treat with the negative pressure in still and dwell, one is access. Two is how high risk I feel that the patient is for renecrosis or infection or needing serial operative debridements. If they're very high risk, I will take the hypochlorous acid. If it is somebody that I am being more cautionary or proactive with, then I will go ahead and use the saline for the negative pressure in still and dwell. The soak time and dwell time, there is some variance, but essentially the key is about 10 minutes every 2 hours. There was a study that was done looking at, what happens if we let that dwell time be longer to 20 minutes, and the 10-minute dwell time actually did better. But again, creative license, I will play with that a little bit depending on the patient and how much I suspect that there's renecrosis. But on the whole, we're going to do about a 10-minute dwell time every 2 hours. Okay, so that's the negative pressure in still and dwell. Another good innovation that we probably all have at least some familiarity with, if not, this is a great thing. This was another thing that I included in this talk with you all tonight, because I was a little bit of a slow onset user of this as well, simply because, again, coming from a surgical field, I had just been trained to the tradition, and it took me a minute. But the minute that I realized the benefits to my patients and how much this optimized their care and reduced the number of surgical site infections that I was seeing, I was immediately sold for this for my patients. I want to start with the closed incision discussion with a study that was done in the Journal of Vascular Nursing. So often with things like this, especially post-surgical, when we're sending our patients home from the post-surgical recovery unit, if it's an outpatient surgery, so often I think we miss that care coordination piece. And the patient goes home with a dressing on, right? And we tell them not to take it off or to take it off and shower or don't shower. And then that might be written on their discharge summary, but in their discharge summary, there's 19,000 other things. And I think we're really oftentimes missing the boat with regard to teaching our patients what this looks like. What do you do if you drain through your dressing? What do you do if you have signs of infection? Do you have other dressings to put on? Should you notice these things or need to change your dressing? And I think that the closed incision device optimizes that pretty organically. But this study showed that with the negative pressure, the closed incision, we still need to make sure that we're talking to our patients. We need to make sure that they know who to call, when, what, and why. But it also found that patients felt empowered by these devices, that when they got that individually tailored information, the patient actually felt like they were getting the most optimal device and like they were really doing something active in their care post-operatively. So I want to start with that, because I think that, when I look at things, that's always my first thing is, one, is there evidence and research behind it? And two, how is this going to impact my patients? And this is something that you can see there. That's a patient who underwent a pretty complicated bypass surgery. And we did not use the closed incision dressing initially, and he ended up dehiscing. And I ended up treating that leg for over a year, that distal incision. So this is a patient that retrospectively, I think, man, I really wish I would have done that. I think it would have really helped him. So some of the studies that look at the closed incision dressing, we're essentially improving that lymphatic flow. So by applying the negative pressure and decongesting that microcellular level, we're allowing the lymph system to open and really drain. When you cut through skin and fascia and muscle, you're going to have an inflammatory process. You're going to have some localized swelling. So that closed incision dressing allows us to just decongest and really open that. It decompresses the tissue, and that improves the perfusion locally to the incision site. It's appositional force, so it's going to push the fluid in the direction that we want it to go. And then there's still that little bit of the macro situation, right, where we're actually applying tension with that appositional force to the incision itself to help it close the way that we want it to close. So it reduces edema locally. It acts as a barrier to external contamination. So especially for me, I'm in the vascular world. We do a lot of, an iliofemoral endarterectomy where we're opening the groin. A lot of our patients are overweight, very, very hard area to keep clean. So the closed negative pressure, the closed incision is going to decrease the risk of infection simply by acting as a barrier to some of the bacteria that naturally lives in a lot of the areas that we're doing surgery, right? It still delivers your continuous negative pressure. It helps to hold those incision edges together. It decreases the lateral tension of the sutures or the staples. So it actually gives whatever closure device you used that little bit of support. And just like traditional negative pressure, it's going to remove the fluid and infectious material. So even if you're looking at, a midline abdominal incision where your natural tension, especially when you lie down, is to pull this way, this device is going to help at least those skin edges kind of counteract that. There are studies to show that we are decreasing surgical site complications, which we know are huge from a regulatory and financial standpoint, but more so it's huge for our patients. The thing that we do not want to see is to do a big surgery on a patient and have them come through the surgery really well, but end up back in the hospital and then potentially at a post-acute care facility simply because they ended up with a surgical site infection, needed subsequent debridement, and then we're treating that wound for ages and ages to come. So I think that, when I think about using this dressing, that is one of the huge things that has benefited me is we did see a reduction in our surgical site infections. Lots of different shapes, sizes, and wear time. So essentially 7 to 14 days. You can see depending on, the area that you are looking at for the surgery, the different options that you have there. I do recommend, if you aren't familiar with that yet, to look at that. At first I started using the linear ones and then I kind of saw some of the other ones and it really opened my mind. All right, so we talked about the negative pressure instill and dwell. We talked about the closed incision. Now, this is my actual favorite thing to talk about. This is one of the most recent innovations via Solventum that I was really excited about when it came out, and I'm still really excited about it. So the novel negative pressure therapy, or peel in place, this also is going to be something that really, I think, is going to revolutionize the way that we look at negative pressure and our ability to apply negative pressure to even more patients where it is the right time, right place, right setting. I do want to emphasize that, even somebody like me, I've been doing this forever. I get access to something like this. And in my head, I'm so excited that I'm thinking, I want to do this on that. I want to use this on that, and I want to use this on that. I do want to emphasize that with any dressing, especially with something that is new, we want to make sure that our patient selection is optimal. So the peel in place dressing is not meant to replace the negative pressure instill and dwell or the closed incision or the traditional negative pressure. We have to be very selective about who we're using this on, but I think it is going to really change the way that we look at that. Again, being aware that the same principles apply as far as when we're using what. The peel in place is essentially all in one, which I'm going to show you. So we talked about the hybrid drape, and that's kind of why I went through that so much tonight, because that is what is used with the peel in place dressing. It used to be that, right, we talked about we have to cut the foam, get it to the size, or if we're using the Semplace, we're still, kind of tearing it and trying to make sure we're getting it in there. I don't know about you all, but the number of times that I've been alone in a room, I'm putting negative pressure or any dressing really on a sacral ulcer, and I don't have help, and I'm kind of trying to keep the patient comfortable. I'm holding them over with one hand. I'm trying to get the dressing material in the right place, hold it there. I end up, applying drape and my hand sticks to the wound and then I can't get myself away from it. So for some of those dressing changes where, we don't have access to help, we are trying to get things to fit in the wound exactly, and we're having trouble, this is going to be a huge help. It is all in one. So essentially we're not putting anything in the wound. We peel and we place, and I'll show you in just a second. This also allows us to change the frequency of our dressing change from on average 3 times a week to on average 7 days of wear time. We are no longer cutting that foam, which again is a huge, huge paradigm shift. That's something that, whenever we're kind of learning about this in my hospital, in my clinic, at sessions like this, it's so hard to conceptualize, but we're going to go through what that looks like. But we're all so used to putting something in that wound that it's, until you really see it and feel it, it's hard to get past. Those drape maneuverability issues that we talked about really are no longer a thing with the peel in place dressing. We have an integrated single non-adherent layer, so we're protecting the skin already. And then it's a pre-cut hole already for the trackpad. So again, I don't know about you all, but oftentimes when I'm in and I get all done and my dressing looks beautiful and I'm really happy with it, and then I go to cut my trackpad hole and I accidentally snip off the tip of my glove and nearly snip off my finger. So with this dressing, that trackpad hole is already cut. So some of the things that where I've seen this already impacting my patients and my communities, one is a 7-day wear time. So, you know, in Toledo, where it's smaller, I actually have fairly good access to home health, but we are starting to see post-COVID and post other things and insurance changes where home health agencies can't accept patients who need the 3-time-a-week dressing changes. They don't have the staff, they don't have the resources. So one, this has improved my ability to get home health for my patients with negative pressure because of the dressing change frequency being less. Also, for my patients that don't qualify for home health, it's easier for me in the clinic to be able to sell this to the clinic teams who are putting this on. It's decreased time, and they only have to come in on average, again, you know, switching a little bit where needed, but on average once a week. So for both the clinic administration who's looking at the beans and counting the beans, but as well as for our patients and our staffs who are only going to have to come in once a week, as well as with the home health nurses. The other thing that we're seeing that's a huge benefit with regard to the peel and place is the time for application. Because we're shortening the time of application, it gives us more time to assess our patients, talk to our patients, really look at the wound and make sure that we're looking at things closely, because the dressing itself is so easy to place. So this is actually a brand new PA in my hospital. She had been a PA for approximately 2 months, and you know, I tend to kind of throw them in and stay with them, and she actually did a phenomenal job. We went through it. She was able to peel, she was able to place. She did it well. So I'm also thinking that, you know, the more that we use this, we're going to see a little bit more standardization in how this is applied, and in the right wound, in the right patient at the right time. Potentially, you know, we're not having the issue with leaving foam behind, or I don't know if you've seen a lot of times, you know, instead of filling the wound, we're really stuffing the wound with the traditional negative pressure. So I think as we learn about this dressing, we're going to see some of those issues mitigated as well. I talked about the benefit of the peel in place in the ambulatory care setting already. The nurses that I work with in clinic absolutely love it. Like, they just think it's fun. The patients love it. And you still get the satisfaction of seeing that dressing draw down and being able to really see what it's doing. So like I talked about it, it's an integrated design. I was a little bit sad about this, right? But I've gotten over it, where it eliminates the arts and crafts. So I can remember when I was first trained to do negative pressure, long time ago. It was an LPN that had trained me to do it, and we called it arts and crafts because, you know, I don't know how long you've been doing this, but I can remember, you know, you wanted to cut the foam away from the patient so you weren't dropping things in, and you know, we actually had fun doing that. So it was a hard transition for me, but that integrated design really makes it such that you can literally peel it and place it. The average application time is about 2 minutes. And again, the wear time is about 7 days. So what it is essentially that silicone layer. There's a perforated non-adherent layer that fits on the underside of the foam. And then you have the foam, and then you have the hybrid drape over that. So essentially the foam is sandwiched in between those two things. The fenestration is what still allows the similar action that we're getting with the traditional negative pressure. So it allows us to still pull that fluid out and make sure that we're getting the drainage out of the wound. Okay, so you can see there kind of piece by piece what we've got going on, what that looks like. As far as sizing for the peel in place, the small dressing, essentially a wound that is 2 centimeters in depth, medium 4 centimeters, large 6 centimeters. Okay, so you're going to size this primarily by depth. The caveat to that is that you do not want to use this in a wound that has tunneling. Okay, and remembering the difference between tunneling and undermining, that the way that I think of tunneling is literally like you're driving through a mountain and you've got that narrow little tunnel that you're going to go through, right? It essentially fits the width of the cars, or, you know, in the case of a wound, a finger. It's a discrete tunnel. Undermining is more like a pop can. You snap open a pop can, you can kind of stick your finger in and around. You can have up to 2 centimeters of undermining in any size wound with the peel in place. Okay, so small dressing is 2 centimeters, medium is 4, large is 6 by depth. We aren't going to be using this in wounds that have tunneling. We can use this in wounds that have undermining, but we want that undermining to be less than 2 centimeters. With regard to this, another paradigm shift is that we actually want the foam to extend beyond the wound and to touch the peri-wound skin. So when we think about the way that I can kind of conceptualize this to understand is, I don't know how many of you are familiar with positive bolstering, where when we did have some undermining or some tunneling, you protect the intact skin with drape and then you put the foam over that. Similar concept, that we want that foam overlying the intact skin, because that's where, similar to the closed incision dressing, we're going to decongest the lymphatics that are surrounding that wound. We're also going to make it a more homogeneous drawdown. So instead of only drawing down within the columns of the foam, we have a full drawdown around the wound. So this is something that, because of that fenestrated underlayer, it is safe and recommended that the wound is, or the dressing is, larger than the wound. Doesn't happen very often for me, but if I have a wound that is larger in size than it is in depth, you size up. So you want to make sure that you accommodate the depth, but if your wound is larger than it is deep, you want to make sure that you're still overlapping. So you can size up to make sure that you accommodate that. In the States, I haven't yet had any issue with insurance when I'm trying to treat a smaller depth wound with a larger dressing. Again, this is somewhat new, but so far that has not been an issue at all. The thing here is that we do not want to mix this with any other foam type. So we are not putting white foam in the wound. We're not putting black foam in the wound. We are simply peeling and placing. And we still get that benefit of the macro and the micro strain. So with that, we talked about a couple of dressing options tonight. I really want to emphasize again that we have to look at the whole patient. We have to do a full assessment, see what their comorbid factors are. I always say that the medication reconciliation is the window to a patient's soul. How many times, I don't know if you've asked your patient if they have rheumatoid arthritis and they say no, and then you look and they're on Remicade or methotrexate, right? So we really have to make sure that we're looking at all of these factors like we talked about before, so that we select the right dressing at the right time for the right patient. We have to make sure that the people around us have access to the dressing, that they have the training that they need to apply the dressing, and that we're really looking at the situation as a whole before we select which dressing type we're going to use. So you have to select that dressing based on the wound characteristic, but also based on the patient's characteristics, right? And you kind of learn, like I said, I'll use the negative pressure and still and dwell in the patients that have a lot of comorbid factors that I suspect are going to renecrose. If it's a relatively healthy patient, they have a sacral ulcer, paraplegics that are well offloaded and eating pretty well, and we're not as worried about the necrosis, I'm going to use the traditional negative pressure wound therapy. So you really have to be cognizant of that and make sure that you're selecting the correct dressing at the right time. I already kind of talked about what are the benefits of this is the care continuum, right? I know most of my patients, which we'll talk about, they're going all over the place. They're back and forth. This is one thing that can remain constant for them. So ultimately, the choice of negative pressure, especially for me, is I always feel like I'm doing my patient good. I'm doing them well by choosing negative pressure, because not only is the evidence there, but clinically and anecdotally, we see the benefit of it. It is scientifically sound. And as that science changes and we learned more, the device has also kind of innovated with that. So lots of dressing algorithms around. If you don't use something like this, I recommend you look at it. Most of us have seen these, right? If a wound is dry, unless it's an ischemic wound, we want to get it moist. If it's wet, we want to dry it out a little bit. We want to be looking at pH. We want to be looking at the local wound factors, using the acronym TIMERS. So TIMER is a consistent one. Doing a lecture with Kathy Milne, who actually pointed out the S for TIMERS, adding that social situation and making sure that the dressing that we're choosing, can be fit into the patient's social situating, making sure that we're looking at that care setting transition, knowing that there's no best answer for one wound or one patient all of the time. So we also have to be flexible and willing to kind of work through that. So this is the linear path that most of my patients travel. I put this slide in almost every talk that I give, simply because it does demonstrate kind of the systemic complexity that we deal with, right? So our patients are in and out of the hospital, they're back and forth. So we really need to make sure that as a team, we're collaborative. We communicate clearly, both written and verbal. We made smart sets in our EMR so that we have the ability to really say what we need to say. And we try to do that not just on the discharge paperwork, but actually separately, so that our receiving nurses don't have to go through 19 million pages to get to what they need. We have to make sure that it's patient-centered. Oftentimes, patients are going to be their best advocates. If they understand what you're doing and what you need and what they need to get you there and get themselves there, oftentimes they are going to buy in. So involving the patients and families is really important. With that, we've done a lot of kind of what we're doing tonight. We do a lot of lunch and learns with our hospital nurses and our ECF nurses just to allow everybody to meet. We try to get everybody in one room so that, when you're calling a clinic or you're calling a nursing facility and you get Sally, you know what Sally looks like. So just doing some of those educational sessions with everybody to get everybody on the same page, but at the same time, using the standardized protocols that are in place. So that while we do critically think and we change what we're doing, we're also true to the evidence and what we need to be doing. With that, I do want to mention that one of the ways that we've been able to consolidate our coordination, especially in the discharge from the inpatient to the post-acute or outpatient setting, is the consignment at discharge, which is where essentially you have the negative pressure available to you on the inpatient side. Patient has their dressing on, you just simply unhook, hook to the portable or the ActiVac, and then they're able to go home from there. So if you're not familiar with that, there's actually studies behind that as well, being able to decrease length of stay, patient satisfaction, and making sure that we're really coordinating their care well. All right, so now I want to just quickly go through some cases that kind of go through that transition and why and what and who we're using when. So the first case, this was a large abdominal wound, post-renal transplant, 65-year-old female. You can see her past medical history there, not only the renal, but she's post-cabbage. So this is a really sick lady. I use this case to demonstrate a couple of things. One is the power of persuasion. So for us, in my local area, oftentimes it's hard to get surgeons and other services to consult. Even though I've been where I was, forever and ever, oftentimes services don't really want to let go of their wounds. So the first thing with this is that we were not consulted on this patient until essentially after she had already had a dehiscence, an infection, and a washout. And then it was the transplant advanced practice provider who kind of called me and was like, I think we're going to need some help with this lady. But it still took us a little bit of time to get consulted there. So you can see initially July 10th, they were using essentially a wet to dry dressing. They were putting Curlix in there. You can see the quality of the tissue there on the 18th, not so great. Still not getting good wound healing after that incision and drainage. So unfortunately, she did undergo a second washout on July 22nd. At that point, we were involved, and this is a patient that because she had already had 2 washouts, she's immunocompromised, she's post-renal transplant, she has lots of comorbid factors. I was very concerned that she was going to need serial debridements. This is the lady that wanted to get out of the hospital, so we used a negative pressure instill and dwell on her initially while she was in the acute care setting to try to reduce the need for repeat operative debridement. I do want to emphasize that even as we're doing these things, it's important to make sure that we communicate and that we maintain that multidisciplinary care. So we had infectious disease, the transplant nurse practitioner and I were talking multiple times a day about this poor lady. Our wound and vascular services one, so we were on board. But ultimately with this patient, her involvement and the involvement of her family was absolutely crucial. So she was discharged to skilled nursing facility on August 4th. At that time, we transitioned her to the ActiVac. We had not great granulation tissue, but we didn't any longer have the necrosis or the slough. She had gone through the inpatient stay. She did not need any further operative debridement. And this is a patient who was really motivated. She wanted to lose weight. She wanted to be going. So she discharged on the ActiVac. And then you can see about 3-4 weeks later, the progression of the wound. So when we saw her in clinic that first time, she was actually doing really well. Again, hypogranular tissues. So in that situation, I'm going to be looking at what her labs are. Is she anemic? What's going on? How's she eating? But again, we did not have that slough and her wound measurements had changed dramatically. At that first clinic follow-up, she did have some wound pain. So this is the traditional negative pressure, right? So we mitigated that with some hydrocolloid around the wound. Continued to treat her at home with home health with the ActiVac. We were very, very, very collaborative with her home health service. This is a very large wound. Again, the patient's very meticulous, very motivated. So we were having very frequent conversations with the home health nurses, which in my opinion, especially for the comfort and the confidence of the patient is really important for us to be doing. She still did have some pain at the edges of her wound, but it was improved. We focused a little bit more on her diet at this point. She was up and moving. She was starting to feel better. Therefore, she was eating better. But at this point, she was really frustrated. She really wanted to swim. So this is a patient who was trying to lose weight, swimming prior. And I use that to say that at this point, when she's starting to get frustrated, just sitting down and talking to her and figuring out what made her tick gave us a goal. And the goal wasn't as much wound closure as it was she wanted to be in the pool. So we really used that as motivation for her. Continued to follow her. So we're about 2 months out in October. At this point, we did get access to the peel in place. She did not any longer have more than 2 centimeters of undermining. At that inferior edge, you can see there was a little bit of undermining. It was about 1 centimeter. So we used hypochlorous acid to clean, a collagen dressing, and then we used the peel in place over that to give her a little bit more mobility because she was still having some pain at the edges. When we got her on the peel in place, her pain completely went away. She did not have any issues with those wound edges or the dressing changes anymore. About 1 month later, we started her on collagen. She was doing really well, closing really well. Unfortunately, she got COVID. We were still communicating with her home health nurse. She had closed immediately prior to having COVID. When she got COVID, we all know that remote infections, right? When your body's fighting something, it's going to let the wound kind of take second stage. So she subsequently reopened. We were able to start a collagen dressing via telehealth. And then she did go on to close and was able to get in the pool. So January 29th was the last time that we saw her, and she was closed. To allow some time for questions, I'm going to go through this one pretty quickly, but I call this the quintessential case because this is another case that this poor woman had just about everything under the sun going on. So this is a patient that presented with atypical vasculitis. She had had workup for pyoderma. Pretty much everything was coming back negative. She had a history of bariatric surgery, suspecting that there was a vasculitis related to the GI situation. You can see here when she necrosed, we did go ahead and debride her. Because of her risk as well of renecrosis, we started her with the negative pressure instill and dwell as well. You can see there the columns kind of tissue. We're starting to see some good granulation tissue, but she has an extensive wound with tendon exposure. Unfortunately, this was a patient that had a lot of pain. She had a lot of isolation, family issues. Her husband had dementia. English was her second language. She was all by herself. So her pain was actually exacerbated because of her psychosocial situation. She did not tolerate the negative pressure instill and dwell well. So luckily at this point, I did get access to the peel in place in the acute care setting for her as well. So this is a patient that was in and out of the hospital multiple times. I made the mistake initially of when we discharged her to the nursing facility on Activac, I decreased the setting. You can see there I had her on about 75 millimeters of mercury because of her pain when we discharged her. The peel in place is not yet available in the extended care facilities. So I discharged her on the Activac. She did okay, but probably because I didn't establish that relationship with her extended care facility, when she didn't tolerated it, they were afraid to push it and they didn't know who to call. So you can kind of see the change in the like healthiness of her tissue because we were not using the VAC. It was not used as consistently as we would have liked. So with regard to that, the second time we discharged her, I made sure that I called the nursing facility, and you can see the transition there from the type and the quality of the granulation tissue when that negative pressure was applied. But with that, we kind of started to joke with this poor woman because she was in and out of the hospital with PE, all kinds of other issues. When she would come to the hospital, we would use the peel in place, and then she discharged, and she did tolerate that Activac with the decreased setting, which we modified. But we actually started to joke that she was, essentially trying to get readmitted because she really loved the peel in place. She really, tied into that dressing and felt like she was doing something really good. It didn't hurt. She actually did really well with it. So you can see there, about 2 months, she had another washout. We put a CTP or a camp on her ulcer, continued the portable negative pressure therapy in the extended care facility with a non-adherent over that camp. And you can see there, again, to revisit, the quality of her granulation tissue with the continued negative pressure therapy usage. Unfortunately, because of me career transitioning and her being elsewhere, I was not able to follow her completely to closure. But I do use her as a good case, one, because of her buy-in with regard to the peel in place and kind of that back and forth and how we decide what. Sometimes it's simply just patient preference, as long as that fits the clinical situation. So last case again, being cognizant of time. This is one that I just love to share. This was 70-year-old-ish guy, hadn't been to the doctor in like 5 years, came to us with a raging diabetic foot infection. He did not look at his foot once from the time that he presented until the time that we got him closed, which was over a year. So this is a gentleman who, had some distrust in the healthcare system, was fearful. When we took him for the emergent surgery, which you can see the extent of tissue loss here, he said, absolutely under no circumstances are you amputating my leg, which, in our setting, we're not apt to do anyway, unless it's truly life over limb. But this is a gentleman that really, really bought into limb salvage. So with that, again, as we look at some of the factors we need to consider, we need to be aware as woundologists of all the different guidelines that are out there. So with the diabetic foot, being aware of the Infectious Disease Society and other guidelines that are available to us with regard to how to treat those infections, and making sure that we're really looking at things clinically. I have the benefit of having a ID pharmacist at my facility. So our ID pharmacist made this awesome laminated chart of those IDSA guidelines. So when I talk about some of those systematic tools for our residents and newer APPs and nurses that are coming in, everybody's looking at the same thing. Everybody kind of has that treatment algorithm. So this is a patient that also had PAD. So we got him, the infection controlled. He had serial debridements until we got the infection controlled. And then he underwent an angiogram, had an angioplasty. There you can see of the right anterior tibial artery, perineal artery, and posterior tibial artery, as well as a drug-coated balloon angioplasty of the right SFA. So he had pretty significant disease that we were able to optimize. This is a patient that we used that instill and dwell on initially, again, because of his diabetes, because of his concurrent PAD. We suspected that he was going to renecrose. After we got that infection initially controlled, we didn't want to have to keep taking him back to surgery. So thankfully, once we did the angiogram and that last washout, he did not need any more operative debridement. So you can see kind of there the progression use of the negative pressure instill. That picture on January 9th, not the best looking tissue, but you can start to see that we're getting that granulation tissue. We're starting to get some coverage, and then you can see the improvement about 5 weeks later from that. So this is a patient that we continued to follow in clinic. When he left the acute care setting, we stopped the negative pressure instill, put him on an Activac. So this was a patient, again, who was looking to be ambulatory. Obviously, he wasn't walking quite a bit right away, but we do balance that, right? Because we don't want them to end up with pneumonia and deconditioning too much. So this was a really active patient. Didn't want to be in the hospital. So we transitioned him to the Activac. He did end up going one more debridement during the course of his therapy at that fourth toe amputation site that had renecrosed. He had his frequent arterial surveillance. We were making sure that we were following the guideline-directed medical therapy with his aspirin, his Plavix, his statin. His family was heavily involved. And the key with him is kind of that flexibility and making sure that every little victory that we had, we celebrated. So like I said, this is a gentleman that really did not want to be there, right? He did not look at his wound the entire time. I still think, I saw him just about a month ago, and I still don't think he's looked at his foot. This is a patient that kind of emphasizes the need to critically think, to make sure that you're meeting the patient where they're at, to make sure you're meeting the family where they're at, and meticulous attention to detail. Again, this is a patient who didn't want amputation. So that transition from the instill to the traditional negative pressure, the VAC holidays when we needed to, making sure that we're paying attention to his arterial surveillance and making sure he has glycemic control and getting endocrinology on board, getting infectious disease to weigh in. So really meticulous care. He closed almost exactly 1 year to the date of presentation. And I counted in our electronic medical record how many touch points we had had, and we had had over 250 touch points with this patient or his family. So you can see, that with all of these new devices and innovations, we still have to make sure that we're taking really great care of our patients. But when we do, and knock on wood, I definitely don't want to say it out loud, but this is a patient that he's almost a year out from closure, and he still has his foot, he's still walking. He has some open areas in that scar tissue periodically. He stepped on a nail and didn't realize it at one point, but he's trained to come in really early. We treat it, and thankfully to this day, he remains closed. So with that, looking at all the complexities that we just talked about, it's really useful to use your clinical algorithms, know your guidelines as far as, looking at the Society for Vascular Surgery or your vascular guideline, and knowing what that standard protocol is, but then also making sure that you have some flexibility and critical thinking with where you are and what the patient's doing and what the patients need, what the patients tell you, are they having pain? and all those good things. Also making sure that we consider that step down therapy. So we go from the instill and dwell to the traditional for those patients that were having pain. Some of these cases are the first cases that I use the peel in place on, but making sure that we're really being selective with regard to when and where so that we optimize the outcome for our patient. And then again, making sure that we're exercising shared decision-making with both our patients and our families. So we do
I
have some
need
time for questions.
That was, I think I can hopefully speak for everybody in the chat here. What a fantastic presentation. And those cases were so, so amazing. Thank you for sharing that with us. And wonderful healing. That was so, so cool to see. So thank you for taking us through that. Loved your emphasis on the team approach too. And we're going to have lots of different nurses from different areas of the interprofessional team. And we're talking about handling wound care. But it's great to hear that where you're working too, that there was so much of that collaboration. You talked about the education that you're doing together as well. Actually knowing who you're going to be calling later, all those kind of things were fantastic. But fantastic presentation. I'll remind everybody you can put some questions in the Q&A box here. We'll start with a couple and see how we can get before the end of the hour here. So one, I think you answered it in, especially in your second case there, but just wanted to reiterate that there is an opportunity to use negative pressure wound therapy on wounds that are arterial and or have necrotic tissue. So just maybe re-emphasizing a little bit from that second case even to look back on. And then one question we had here was, is the peel in place going to stick or adhere directly to the wound bed? Or just to clarify, should there be a non-adhered contact later applied first?
Great question. And I apologize I didn't get that in there. So that the fenestrated underlayer essentially serves as your non-adherent layer. Do not need a non-adherent layer because that is essentially it. It's built in.
Fantastic. Okay, well, thank you for touching on that there. I'll just reiterate if anyone does have any questions here. We still have a couple of minutes, so please, we had some great cases here. If you want to reiterate something or find something from one of the presentations, we still got it up here. So if you have any questions, throw them in there while we got some time. Just seeing so many very informative presentations. Thank yous in the chat, of course, as well. These are great. Well, I'll tell you what I'm going to do here too, I'll leave it on for a couple seconds. I'll just reiterate to everybody that we are going to be sending out the certificate of attendance to everybody. In that email, you're going to be getting two things. One is a survey, and there's also going to be an opportunity to opt in to be contacted by one of our Solventum reps. So if you have any specific product questions, if you want to talk more about Peel in Place, if you want to know where it's available in Canada, potentially where your facility or in what area you're working in, that's a great way to be able to ask that. And if you have any other questions, reply to that email and we can always find the correct contact, whether it be through Solventum or through an NSWOCC or to Dr. Bauer if we can. But a reminder that we're going to be, we did record this presentation today, so it's going to be available to watch after the fact on our website. We'll have the link in that same post webinar email. Just give us a day or two. We'll have it in your inboxes right away. But as we approach the hour and as everybody says, great presentation and thank you again, I will thank you as well from our side here at NSWOCC, Dr. Bauer. That was fantastic. And we'll thank Solventum again for making today's education possible. And we know that you're preparing for a big move, and it sounds like hopefully it's going to be warm and amazing in Georgia where you're going. So thank you again for coming with us today, and best of luck with the move.
Thank you so much. I really appreciate being here. Thank you to both you and to Solventum.
Thanks, everyone. Have a great evening.